Hello, my name is John Davis, and I am the current practice chair and vice chair for the Division of Rheumatology at Mayo Clinic in Rochester, Minnesota, and associate professor of medicine in the Mayo Clinic College of Medicine and Science. And today I'm talking about our article that has been published in the Mayo Clinic Proceedings that is entitled Evidence of Diagnostic and Treatment Delay in Seronegative Rheumatoid Arthritis, Missing the Window of Opportunity. Rheumatoid arthritis is a common autoimmune inflammatory disease of joints that affects between 0.5 and 1% of the world's population and is among the more common types of arthritis that we encounter in practice in rheumatology and by medical providers probably worldwide. It's a significant problem for which sometimes the diagnosis can be challenging and never more difficult than in the patients who lack any detectable markers for autoimmunity and really just are presenting with signs and symptoms of chronic joint pain, swelling, morning stiffness, and the impact of the disease on their health, fatigue, tiredness, etc. And so in this study, we're really very interested in really time to diagnosis and time to fulfillment of classification criteria. We know that it's very important to make a diagnosis of rheumatoid arthritis as early as possible. And many studies have shown that early diagnosis leads to better outcomes in terms of achievement of time to remission and reducing the impact of the disease on the individual, improving their functional status, and preventing bad outcomes of the disease like extraarticular disease manifestations, cardiovascular disease even, and certainly the prevention of joint damage. We have concern that based on previous studies that have shown that among more recent cohorts and populations, patients with seronegative disease may actually have a higher disease activity at the time of diagnosis as compared to seropositive patients rather. And that led us to hypothesize that perhaps patients with seronegative arthritis really are diagnosed later and fulfill classification criteria later than their seropositive counterparts, and that may explain why there is this gap in their outcomes. So we had the advantage in our population-based inception cohort of patients with rheumatoid arthritis to be able to go back and look from the time they first were seen by a rheumatologist or any healthcare provider and documented to have joint swelling. And joint swelling was an important indicator of when they first had contact and were eligible to be evaluated and diagnosed for rheumatoid arthritis. And we looked at that time from first joint swelling documented by a healthcare provider in our healthcare system to the time they actually were either diagnosed clinically with rheumatoid arthritis by a rheumatologist or to when they fulfilled classification criteria. And we investigated both the 2010 American College of Rheumatology and European League Against Rheumatism classification criteria versus the older 1987 ACR criteria. What we basically observed is that patients with seronegative rheumatoid arthritis had a longer time from first joint swelling to when they were met criteria for both the 1987 criteria, which is actually 48 days versus 2 days for the seropositive patients, and for the 2010 criteria, which I believe was 14 days versus 0 days for the seropositive patients. I think the overall impact of the study is that we certainly have difficulties in diagnosing people with rheumatoid arthritis when antibody tests, that is rheumatoid factor, and anti-CCP antibodies are negative. And certainly calls on a need to identify better tests and really diagnostic markers to identify people early on. A couple of the implications of the work, we observed that patients with seronegative RA took longer to or had a delayed time to first remission as compared to patients with seropositive RA, suggesting there's an impact of this delayed diagnosis potentially on the achievement of remission, which is a very important outcome in the current field of rheumatoid arthritis management. Some might question that finding because we didn't see many of the core set measures of inflammatory arthritis as being different between the patients with seronegative or seropositive RA during 5 years of follow-up. What we saw is that the patients with seronegative RA had this persistent elevation of their patient global assessment, suggesting that there may be some impact of delayed diagnosis and delayed time to starting first treatment on the long-term experience of the disease. So, again, at the end of the day, this study calls on a great unmet need in terms of diagnosing seronegative rheumatoid arthritis and on a need to improve our diagnostic biomarkers for the disease. I thank you and hope you will read our paper, and if you have any questions or concerns, don't hesitate to reach out to me as the corresponding author for the paper. Thank you very much for your interest in this podcast.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.